Musculoskeletal and Anti-inflammatory drugs lecture. Disorders and diseases. Degenerative disc disease, arthritis, bursitis, gout, sprains and strains, and there are many more diseases in this class. Classifications of drugs. We have skeletal muscle relaxants, NSAIDs, also known as non-steroidal anti-inflammatory drugs, and corticosteroids. Skeletal muscle relaxants. The most commonly used medications are Soma, Flexeril, Robaxin, Zanaflex, and Loracil. The most commonly prescribed, I would say, that you will see in the clinic is cyclobenzaprine or Flexeril. Soma, you should know, is a controlled 5 substance, so there are restrictions on prescriptions. Patient education. Patients should not take muscle relaxants with Benadryl or sleep aids. There's already a sedative effect with most of these drugs, and then with taking these types of medications on top of them, patients are at high risk of other side effects. Patients should not operate motorized vehicles while taking muscle relaxants due to the sedative effect. Anti-inflammatory drugs. They reduce inflammation. There's 2 categories. There's the NSAIDs or salicylates, and then the COX-2 inhibitors. They decrease inflammation by inhibiting the production of prostaglandins. Salicylates are also known as aspirin, and they are considered NSAIDs, believe it or not. NSAIDs, no pain, no flame, and no heat when we meet, is the saying. Analgesic, anti-inflammatory, and antipyretic. Ibuprofen, you can take you can take up to 1,600 milligrams. And then Aleve is a little bit different. You can take up to 1,000 milligrams a day. So it's very important to know those dosage differences when you're talking to patients. It's important to watch out for stomach distress, dizziness, rash, heartburn, occult blood loss with these 2 medications. COX-2 inhibitors are NSAIDs that have anti-inflammatory, analgesic, and antipyretic activities. They are partially selective. They don't pose a bleeding risk like other medications do, such as aspirin. They increase the risk of recurrent MIs, however. So patients who have cardiac problems or have a history of myocardial infarction should not take these medications. There's also interactions with anticoagulants and aspirin, your Plavix. They don't allow these medications to inhibit platelets and thin the blood, and they decrease the effectiveness of these medications. NSAID drugs. So we have the traditional Voltaren or diclofenac, which can come in a pill, gel, or patch form. We have Motrin, also called ibuprofen. Indomethacin, also called Indocin, mainly used to treat gout. We also have Ketorolac or Toradol, which is usually used to treat headaches or pain, usually given in an injection, commonly in the clinic. Naproxen, also called Aleve. And then partially selective NSAIDs would be our meloxicam or Mobic. Oftentimes meloxicam is taken for gout, and then Nebutone. And then our selective COX-2 inhibitors are the Celebrex. It is important to note that Celebrex should not be taken with if a patient has allergies to sulfa. It's also important to take NSAID drugs with food in the stomach to decrease irritation. And all these should be discontinued prior to elective surgeries, at least 7 days, if not 14. Osteoporosis is a low bone mass, deterioration of bone tissue, increased risk of bone fractures. Some of the risk factors are age and gender, body size, ethnicity, family history. Preventable risk factors are sex hormones, so a decrease in hormones, we can replace them. Anorexia, decreased calcium intake, which can be replaced. Medication use, such as seizure medications, corticosteroids, and antifungals can have an effect. Also, there's new research out that Depo-Provera can cause osteoporosis. Smoking, lack of exercise, and drinking alcohol. This slide shows the daily recommendations for calcium from the Institute of Medicine. Vitamin D should also be taken with calcium to help the reuptake and absorption of these medications. Vitamin D should have at least 1,500 to 2,000 IUs daily. Vitamin D can also be obtained by sun exposure. Osteoporosis therapy, there's two different types. There's the hormones and the biphosphonates. Hormones such as Evista is an estrogen antagonist on the bones. Calcitonin is a naturally occurring hormone, can be replaced either by sub-Q injection or a nasal spray now. It helps regulate calcium levels in your body and is involved in the processes of bone making. Hormone replacement therapy, such as estrogen, we usually try and stay away from this one as it is linked to higher cancer rates, usually given in the lowest dose possible for the shortest period of time. And then Forteo, which increases GI calcium absorption, can also be given. Biphosphonates, we have alendronate or Fosamax, Boniva, or Actonel. These are the first-line therapies. Oftentimes, Fosamax is used for the treatment of Paget disease. They bind strongly to and accumulate in bones, creating a reservoir of the drug that is released back into the systemic circulation gradually over a period of time. Biphosphonates have a really long half-life. Some research says that Fosamax can stay in the bloodstream for up to 60 years. So the recommendation is to take this medication for a short period of time, given that you will have the effects of the half-life for a huge period of time throughout your lifetime. And this is a fun little slide on Fosamax. Take on an empty stomach with plenty of water and don't lie down or eat within 30 minutes. Generally, we tell patients to take with a full glass of water 30 minutes prior to any eating. Generally, Fosamax is only given once weekly.